Hi, everybody. Welcome to the February 2024 NBS National Pilot Call. We've got a packed agenda, so I think I'll get started with some introductory remarks. So Jennifer's going to help out by moderating the discussion section today and advancing the slides for all of us. So Jennifer, if you could go to the next slide. So NBSTRN since 2010, time flies, has been hosting this monthly webinar to focus on conditions that are either part of routine newborn screening or conditions that are being piloted or tried out either on the research side or the public health side. So we're really excited that you're all with us today to hear an update from our colleagues who were able to present today. Next slide. So Dr. Ki Chan on our team at ACMG is co-editing another special issue with myself. That's part of the International Journal of Neonatal Screening, and we're still accepting manuscripts. So if you have one that's about ready to go or ready to go, feel free to reach out to us or click on the link and read more about the special edition. The next slide sort of gives us a little bit of a highlight of the theme of this special issue, but it's really wide ranging and we're receiving manuscripts from really around the world. So we think this will be a great special issue and really have a broad interest across the newborn screening community. So we invite you all to join in that special issue. Next slide. So today we're going to hear from three groups that are piloting newborn screening for Duchenne muscular dystrophy. We're starting out with Dr. Richard Parad from Brigham and Women's, followed by Norma Tabacoli from the Department of Health Wadsworth Center, and rounding out today with Holly Piet from RTI International. The next slide, I'll introduce all three speakers, and then we'll get started with Dr. Parad, who's actually presenting to us all on his vacation. So Dr. Parad, you've always gone above and beyond, but I think this is an especial, just want to note that as a hallmark of what you've done for us at NBSTRN. So thank you so much.
No problem, Amy.
We really appreciate it. So Dr. Parad's an attending neonatologist and an associate professor of pediatrics at Harvard Medical School. He underwent dual training in perinatal, neonatal medicine, and pediatric pulmonology at Boston Children's Hospital. Dr. Parad is director of the program in newborn genomics in the Department of Pediatrics at Brigham and Women's Hospital. And in addition to caring for newborns in the NICU, he's a core member of the Growth and Development Unit, faculty, and the antenatal consult team. His research focuses on the use of genomic sequencing for screening and diagnosing disorders in the newborn period, as well as clinical trials for improving treatment of neonatal lung disorders. So thank you again so much for your time today, Dr. Parad. Dr. Parad's update on his efforts will be followed by Dr. Norma Tabacoli. Dr. Tabacoli received a Bachelor of Science degree in microbiology and a doctoral degree in molecular biology from the University of Bristol in the UK. As the Director of Molecular Methods Development in the Clinical Virology Program at the Wadsworth Center in New York State, Dr. Tabacoli developed molecular assays for the detection of viral pathogens and was involved in the outbreak response. She became director of the Viral Encephalitis Laboratory in 2004. Dr. Tabacoli joined the New York State Newborn Screening Program in 2007 and has overseen the immunoassay laboratory since 2010. Her laboratory performs screening in congenital hypothyroidism, congenital adrenal hyperplasia, cystic fibrosis, and HIV. From 2019 to 2021, her laboratory performed a consented pilot study to screen for newborns for Duchenne muscular dystrophy. Dr. Tavakoli is currently involved in a pilot to study screening for newborns for congenital cytomegalovirus. She's also worked as a consultant for the Association of Public Health Laboratories and is a clinical assistant professor at the State University, New York, Albany. So again, thank you so much, Dr. Tavakoli, for your time today. And we're looking forward to hearing an update on your pilot efforts for Duchenne. Our first two speakers will be followed by Dr. Holly PA. Dr. PA is a senior research scientist in the Genomics and Translational Research Center at RTI International. Her research spans common and rare disorders and is primarily focused on the ethical integration of new technologies in research, clinical, and public health settings. In addition to Dr. PA's social behavioral research, genetics, and bioethics training, she brings experience with community engagement, the return of individual level results, patient preference and experience studies, and pilot studies that have an objective of informing public health. Dr. PA's expertise in rare disease includes the characterization of rare disease natural history, assessment of symptoms that will have the greatest impact on activities of daily living and quality of life, and screening to diagnose affected children prior to symptom onset. Dr. PA is director and principal investigator of EarlyCheck, Newborn Sequencing Research Study, which currently provides sequencing-based research results to parents of approximately 400 newborns per month. Dr. PA is also PI of the EarlyCheck Duchenne CKMM pilot study, which completed screening in 2023. Thank you so much in advance, Dr. PA, for sharing your expertise and your time today. And so now I'm going to turn it over to Dr. Parad to give us an update on his efforts at Brigham and Women's. Welcome, Dr. Parad.
Thank you, Amy. And again, since the forces seem to be against me today, I just lost internet in the place I'm staying, so I'm on my phone. Please let me know if there's any problem in hearing me. And I'd like to thank you too. I wouldn't have missed this particular last session. I want to thank you and your group for all you've done for newborn screening, having worked together with you over the last 10 plus years. So to update you on, and many of you may have attended the APHL presentation last month. Some of this is redundant, but I have updated it some. This is an update on the status of our still ongoing supplemental DND newborn screening program that's housed at a single hospital, the Brigham and Women's Hospital in Boston, supported by the Cure Duchenne Foundation. Next slide, please. I'll start out with the things, my conclusions and the things that I think we've learned. So interestingly, after screening over 7,300 males, we have not detected any true positives, and I will discuss this through the presentation. We have found about, and I should say using our algorithm, which is a CKMM, which reflexes to whole exome sequencing on the same initial dry blood spot and uses the original PerkinElmer / Revity supplied cutoffs for male and female. So these conclusions are based on this specific algorithm was that we identified about 1 in 1,000 females to be carriers, and about 2/3 of those we detected had pathogenic variants. We found non-pathogenic variants of unknown significance in about 1 in 2,000 males, and these were single nucleotide variants. We tried to make lemonade out of lemons, given that we could not make conclusions with a referent true positive cohort. So we decided to take our, what we believe is a true negative cohort, and use the CK values in a group of babies who were confirmed by sequencing to not have DMD, and we developed some information on those babies. we found they were, if their CK was in the sort of 1 to 3,000 range, there was a low likelihood on repeating their CK that it would was remaining elevated. We did not find the need to go to other genes in the exome data that we had because the CK levels went down on our patients. And we were able to use the information and develop a nomogram for likelihood that an elevated CK level was due to perinatal factors. So this is perhaps more of an adjustment targeted to the clinician end of the workflow rather than the laboratory correction end of the workflow, in allowing a clinician to have some framework in which to present an initial elevated CK value to a family to present the likelihood that that high CK level, given the perinatal factors, might put the baby at risk for being a true positive, as there is a wait for the sequence information to come back. And then relative to my first bullet point, the 7,300 males versus 0 true positives, we asked the question why that was. Was it something we were doing wrong? Or was the incidence different in our cohort? And we, of course, don't know the answer to that question. We have put a blinded true positive through our system, and we just completed that recently. That was completely picked up by our algorithm with an elevated CK and abnormal sequence. So we believe our screen is working. But we did note, and I'll tell you the story of the single case that sort of pointed us to this, that there was a mother, we had gone into a mother's chart to confirm a consent that the laboratory didn't receive. And in going through the chart, our program manager saw that the mother had an expanded carrier screen, or ECS panel, that included DMD, was found to be a carrier, and then went through the whole artificial reproductive technology route to avoid having a baby with DMD. So we thought, well, maybe that is some relevance to why we're not seeing affected males if they're being avoided ahead of time. And when we looked into this more, we found that our hospital screens with DMD the mothers, about half of the mothers who deliver. Now that's probably skewed to the higher side. There may be other regions of the country where expanded carrier screening has not sort of caught on yet, but I think it will be increasing everywhere. So we may have actually a lower incidence of DMD in our population. Next slide, please. Okay, now we'll take a couple of steps back on the next slide and look at a little more detail, just refreshing you on what our algorithm is. We piggyback on to the state mandated newborn screen. So we don't use their sample. We try to stay clear of them as much as we can and not confuse the parents, but they do get a welcome packet when the mother and father come to the postnatal, post-delivery floor, which gives them the opportunity to think about doing a supplemental screen for DMD. It's free, and we give them the time between the time they read the brochure and the time the baby has that state newborn screen drawn to make a decision. Also, their pediatrician comes through and explains mandated newborn screening, and also mentions this program and directs the families to the brochure. Then the parents will sign a consent form if they're interested. We get about 80% of parents saying yes. Then we collect a parallel dry blood spot to send to the laboratories that do the CK and the sequencing. So we do not use the state labs sample. And then We use outside labs. One is the Revity lab that performs the CKMM assay that I believe the other two programs are utilizing, and that's an FDA-approved assay. And we use another lab for whole exome sequencing on the dried blood spots. Next slide. So this is our algorithm. It uses one dried blood spot. We have consent from the beginning to immediately reflex to sequencing if the CK is above threshold. We use the thresholds that were originally supplied by then PerkinElmer, which were sex specific. And you can see them there in the red box on this slide. If the CK level is above those male and female cutoffs, the sample immediately goes to sequencing, which takes approximately another 3 weeks to perform. It's not a rapid whole exome. It's a kind of more regular time duration for results. If the result is below the cutoff, that CK value goes just directly back into the medical record. The parents see the result when it's entered into the electronic record, and that's the end of the pathway for those patients. Next slide. For those babies. For those babies who have an elevated CK, we do try to bring them back for repeat CK, and as per the flow on the right side of this slide, if there's a variant of unknown significance and the repeat CK is normal, we discharge those families from the algorithm. If there's a pathogenic variant, we have set up a follow-up clinic at the adjacent children's hospital, where there's a protocol for intake, which includes a DMD team that has a genetic counselor, a neurologist, and other specialists, and the parents get counseling. They're offered, mothers offered testing, and if the baby needs to be followed, that's done through them. Next slide. Here are numbers from up through the end of last month. We screened just over 14,000 babies. It's about half male, half female. We've sequenced, we've had 388 with elevated CKs, and then another group where the CK was unsatisfactory, but we were able to go on and just go directly to sequencing so that we could not have to collect another sample. As I said, we have no true positives from our native cohort, but we have one blinded positive that went through and succeeded in the system. We've got 10 detected babies out of that 14,000 who have had sequencing variants detected, 6 of them female, 4 of them males. Of the 6 females, 4 of them had pathogenic or likely pathogenic variants. And of the males, those were all single nucleotide variants that were VUSs, and our algorithm does not report VUSs out to families, only pathogenic or likely pathogenic. But we do analyze each VUS very carefully. We have a big discussion to decide whether we want to fall on one side or the other of the VUS. And we have had one male that we lean to the side of this variant is very close to another one that's been reported. So let's bring the child in and do a little bit of follow-up. But that turned out to be negative. As I said, about half of our mothers turned out to be screen positive on an expanded, turned out to have undergone expanded carrier screening, so the mother would have been screened for a DMD variant. And then finally, we are not a newborn screening program like the States. We are a very small program of basically 3 people who are running this, and we don't have the resources to do very aggressive follow-up. Like, I can't send the police out to bring back a family that doesn't want to follow up on things. So for every baby who has an elevated CKMM, we do ask them to come back, even if their sequence is negative, and have a repeat CK, which we do not charge them for. And we can only get about half of the families to come back through our system. But most of those that come back have a CK that is either normal or close enough to normal that we think we can discharge the family. Next slide. So again, about those 4 female carriers, interestingly, 2 of the mothers had undergone expanded carrier screening that included DMD sequencing. And interestingly, both mothers had normal reports. Some explanations here are that the lab did not categorize and these were large duplications or deletions, so they were copy number variants. They may not have categorized them. They may have categorized them as a VUS and not a variant and not reported them out for that reason, because it's a screening test where VUSs aren't normally reported out. It could have been a de novo variant in a baby, which we know happens about a third of the time in DMD. The assay used in these screens may not be up by number of reporting. It may be more targeted on a point mutation. Or there could have been a lab. I don't know. We're kind of looking into that a little bit more as the plot thickens here. But I think there is more to think about in terms beyond just the newborn screen. There's also the maternal screen and how it's done and what's been done and how it's been done to think about in making an assessment. Next slide. Finally, I wanted to talk about our lead part of the presentation, which is trying to take those negative sequence CK babies in the setting of
Did we lose Dr. Parada?
He is there, but it looks muted.
Yeah, let me see.
Can you hear me now?
We can hear you now. Yep.
Sorry. Okay, I'll keep going. We're looking at to use the data to see if we can provide the clinicians with some kind of sense of whether the CK might have been elevated is a false positive because of perinatal issues. Next slide. So we looked at, and the other pilot programs, I know we're going to talk about similar data. On the next slide, we can see that we decided to, this is our, just a quick description of our cohort in terms of the mean or median CK, which is in the 300s. Most of the samples were collected around 30 hours of life. And we only tested babies above 35 weeks, so we don't have data on very preterm babies. So the mean birth weight was around 3,300 grams and about 39 weeks gestational age. You can see the distribution of race and ethnicity. About a third of the babies are delivered by C-section, and of the vaginal deliveries, about a third of them are induced. Next slide, please. So we sought to describe potential risk factors using our data set for CK-MM elevation. We used about 8,300 mother-baby pairs for the analysis, and then we had a validation cohort that contained about another 4,000 babies. These were babies confirmed not to have DMD on sequencing. We linked the CK values to the maternal and newborn medical records, electronic records, and sucked out the clinical information we were interested in, performed a univariate and a multivariate analysis to develop a prediction model, and then optimize that model, keeping in the variables that seem to be most important. Next slide, please. These are the variables we ended up looking at in our univariate analysis. The ones in green, highlighted in green, are the ones that ended up in the final model. They were basically in sort of 4 domains: issues related to the mother and the labor, issues in the delivery room like resuscitation and APGAR scores, factors specific to the baby, sex, gestational age, birth weight, and then issues related to the sample, in particular, at what hour of life the sample was drawn. Next slide, please. You can see here that we have a pretty tight 24 to 48 hour range where samples are collected. So we don't have a lot of outliers of samples drawn too early or too late. And also on the right, you can see percentile curves for sort of 97 and 99th percentile, how they change over that 48 hours in our cohort. Next slide. So these are the variables in 3 different models, and we looked at models for each of the different cutoffs of 97th percentile, 99th percentile, and over 2000, with the latter 2 being, I believe, used by New York in combination, and the 97th percentile being closer to what we used in our algorithm. And they're basically the same variables, although they switch places a little bit. This C statistic, or area under the curve, value is calculated and in these histograms presented in a way to show, if you pull the variable out of the model, how much does the model change? So the variables with the highest bars on the right side, those there's the least change in the model if you pull that variable out. And the variables on the left side with the shortest bars make the biggest impact on the AUC value if you pull them out of the model. And this is one of the methods for trying to choose and keep variables into the model. This is a list of the final variable used, and just as an example, using odds ratios to give you a sense of relative importance of the variables to each other. Shoulder dystocia, it was a very strong signal. So a baby who had a shoulder dystocia had a 12-fold increased risk of having a CK above the 97th percentile. That's sort of how that works. And you can see what kind of fold variability are caused by the other variables: resuscitation, forceps, vacuum-assisted delivery, the mother being a primip, and low APGAR scores, and then the hour of life and gestational age. And this is just next slide is just another way to present these variables to show you relative to each other which ones had a stronger impact in the model on the next slide. On the next, okay, great. And then finally, in the on the next slide is are the 3 curves generated by a model for cutoffs at the 97th, 99th, and greater than 2000 level. Those are all pretty good numbers, with around 0.8 or close to 0.9 for the model. And on the next slide, you can see the nomogram that we developed from these data. And so this would be for the clinician, where up to 400 points can be assigned in this particular model. And depending on the answers to, about 10 questions, points can be assigned, added up, and then if you look at the bottom line, the number of points will be associated with a risk or a probability that elevated CK is high because of that constellation of perinatal factors. Finally, on the next slide, this was from my experience in the CF world and looking at IRTs. We just decided to look at the impact of temperature in the different seasons in the Northeast on CK-MM levels. It did appear that the levels might be a little bit higher in January and a little bit lower in the summer, but this is just something for this kind of an assay that the newborn screening labs will have to keep their eye open for. And I think that is my last, let's go to the next slide, is my last slide. I would just also like to thank my team on the last slide, Yvonne Sheldon and Francesca Coyne, who are the ones who do all the hard work in gathering the samples, getting them to the labs, and getting the results back to the patients. So thank you. That's it.
Thank you very much. And unfortunately, due to time, we're going to have to move on to the next speaker. So Norma, are you still on the call?
Yes, I'm here. Hello.
Yeah, I can advance your slide. Go ahead.
Hello, everyone. Today I'm going to talk to you about a 2-year pilot study that we performed in New York State to screen newborns for Duchenne muscular dystrophy. Next slide, please. This pilot was funded by Sarepta Therapeutics, PTC Therapeutics, Solid Biosciences, Wave Life Sciences, Pfizer, Parent Project Muscular Dystrophy, and PerkinElmer, and I have no potential conflicts of interest. Next slide, please. So today I'm going to give you a short outline about how Duchenne is diagnosed. Previous slide, please. Great, thank you. A little bit about newborn screening for DMD, the goals of our pilot study in New York State, what our screening strategy was, the results of our pilot studies, and some of the factors that should be considered when you perform a first-year screen for DMD. Next slide, please. So in terms of diagnosis, the first-year screen is basically based on the measurement of CK, because individuals with DMD have elevated CK. So this can be done by measuring CK activity, or more recently with CK-MM concentration, because it's more specific and it measures the skeletal muscle damage. The second-tier test is generally detecting variants in the DMD gene. So in general, most of the variants are deletions or duplications, and using sequencing, next-gen sequencing, the smaller variants can also be detected. And in some rare cases, they also do muscle biopsy to detect the quantity and location of the dystrophin protein. Next slide, please. So there have been pilots and projects performing newborn screening for DMD since the 1970s, and most notably in Wales. They were doing screening for DMD for approximately 21 years. Usually the screening was done by measuring CK activity. More recently with the CK-MM assay from Revvity, other groups have done pilot studies. We did one in 2019. RTI also performed one. Boston's using the same kit. In Taiwan, they're doing newborn screening for DMD. Ohio is starting this year, and New York also, and Minnesota will be starting soon also. Next slide, please. We took a consortium approach to perform the pilot study. The consortium included the New York State Newborn Screening Program, Parent Project Muscular Dystrophy, Northwell Health and Columbia Presbyterian Hospitals, ACNG and NBSTRN, and our funders. We also had a New York State permitted laboratory was performing second-tier testing for us. Next slide, please. The goals of the study were to validate a high-throughput first-year immunoassay screen for DMD in a high birth number stage. So in New York, the birth rate is approximately 210,000 a year. We wanted to optimize a second-tier molecular screen for DMD and other muscular dystrophies, and therefore we wanted to identify infants who developed DMD before there were clinical signs. This would allow their parents the opportunity to discuss the diagnosis with a subspecialist, determine a treatment course, and for the baby to participate in clinical trials. We also wanted to use the results to provide evidence which is required for state and federal assessments for the benefits and risks of performing newborn screening for DMD. We wanted to develop the infrastructure to educate parents and healthcare providers about doing newborn screening for DMD. And finally, we wanted to use our results to help nominate DMD to the recommended uniform screening panel. Next slide, please. This slide shows you our recruitment from October 2019 to the end of September 2021, when the pilot was, it was a 2-year pilot. We started with in-person recruitment. And then, as you know, because of the pandemic, we had to shift to remote recruitment. That happened in March 2020. And then the hospitals started going to both in-person and remote recruitment starting in July 2020. And in general, our study uptake over the 2 years was 87%. Next slide, please. This slide shows you our screening strategy. So basically, we screened the same specimens that arrived in the lab for the newborn screening panel. Obviously, we only screened consented babies. Any baby that was below the cutoff for our CKMM assay was considered screen negative. Any who was in the borderline range, we requested a repeat specimen. Any baby who was above our referral range was referred to the specialty care center, and then they would draw blood or a saliva sample would be collected, and they would perform next-gen sequencing for DMD and deletion duplication analysis. And if no variants were detected, then they would open up the panel to next-gen sequencing of a neuromuscular panel, and then the results would be reported back to us and the pediatrician. In March of 2021, one of the labs in the country had approval to perform next-gen sequencing for DMD using dried blood spots. And starting at that time, we started sending dried blood spots to them. And so it didn't require the babies to be called in for an additional specimen. Next slide, please. This is the population that we screened. So we screened approximately 40,000 specimens. That was approximately 37,000 babies. 51% were male, 49% were female. Most of the specimens were collected between 24 and 47 hours of age. That was about 90%. Most of our babies obviously in normal birth weight, so 87% was between 2,500 and 4,000 grams. Next slide, please. The table on the right shows our cutoffs. So we had 4 cutoffs based on age of collection. We had a borderline cutoff and a referral cutoff. You can see that as the baby gets older, the specimens collected at an older age, then our CKMM level cutoffs were reduced. And then the scatter plot on the left shows the scatter for all the specimens that we received. The 4 spots in red are from the babies who were confirmed with DMD or BMD. And the light blue spot shows you the spot that was for the carrier. And the 2 spots at the bottom, the little red one and the light blue one, show you that if we hadn't determined different cutoffs for different ages of collection, we would have missed those 2 babies. Next slide, please. So 296 of our babies had borderline results. That's 1 in 124 babies. 60% were male, 40% were female. Age at specimen collection ranged from 1 hour to 101 hours. Birth weight was, 89% were normal birth weight. And the CKMM value ranged from 644 to just under 4,000 nanograms for these borderline babies. Next slide, please. Of the 296 babies, we received repeats for 277. 2 of the babies who initially had a borderline result were subsequently referred because the CKMM remained elevated. That was one of the male babies who had DMD and a female DMD carrier. We also had 17 families who declined repeat testing, and one of those mothers was a baby. Her baby was a female baby, and the mother was a DMD carrier. So it's possible that the female baby also was a carrier. We also had 2 families who did not return for specimen collection. Next slide, please. We referred 42 infants overall. That's 1 in 876 babies. 60% were male, 40% were female. Age at specimen collection ranged from 6 hours to 3,360 hours. 80% of the babies were normal birth weight, and the CKMM values for these babies ranged from 993 to over 18,000 nanograms per mil. Next slide, please. This slide shows you the median, well, the range that for the turnaround time for our referrals. The median was 8 days of life. There are some who took longer, and the two highest, I believe, were two of the babies where we had to request a repeat, and by the time we received the repeat, the baby was older, and but then we referred them. Next slide, please. So the next two slides show you the results of the follow-up for these babies. So as I mentioned, 4 of the male babies had Duchenne or Becker. One had a duplication of exon 18. One had a deletion of exons 48 to 49. This deletion was in frame. So we expect that baby to have Becker muscular dystrophy, and actually his grandfather also had Becker. The next baby is a male with a deletion of exons 3 to 43. And then the last one was a male with deletion of exon 51. We also detected a female with a stop codon in exon 63. We had two babies, one female, one male, who were carriers of limb-girdle muscular dystrophy. 2 male babies who were carriers of LAMA2 muscular dystrophy. 1 male baby was a carrier of muscular dystrophy, dystrophlacnopathy. Other disorders that were detected were 1 female baby who was diagnosed with Alagille syndrome. This is unconnected with the elevated CKMM. There was 1 male baby who had a possible inborn error of metabolism. There was also 1 male baby who was diagnosed with cerebral palsy and neuromuscular respiratory weakness. 22 of the newborns had a variant of uncertain significance in the one of the genes in the one or multiple genes in the neuromuscular panel. Next slide, please. We had 4 newborns who had elevated CKMM after several months. Those babies continued to be monitored. And then we had several babies who had birth trauma. So 10 newborns had shoulder dystocia. 3 newborns had nuchal cord complication. 2 newborns had hypoxic ischemic encephalopathy and seizures, and 8 of the newborns had breech deliveries. We also had 2 families who couldn't be reached, 6 families who declined genetic testing, and 4 families who declined the neuromuscular panel after no pathogenic variants were detected in the DMD gene. Next slide, please. So we also looked at the CKMM values for all the babies that we tested and all the babies who were tested during the validation. And we published our results in 2 different papers if you're interested. But basically, we found that obviously before we started the study, we knew that age of specimen collection was going to make a big effect. And that's why we had several different cutoffs at different age of the collection. But we also noticed that birth weight, gestational age, gender, seasonality, and race, specifically Asian race, caused influenced CKMM levels. And they should be considered when you're thinking about setting your cutoffs for the assay in order to prevent false positive and false negative results. Next slide, please. So in conclusion, we took a consortium approach to perform a pilot study for newborn screening for DMD. During the pilot study, we screened approximately 37,000 newborns. 42 newborns were referred. 4 of them, their diagnosis is consistent with DMD or BMD. We have 6 carriers of various forms of muscular dystrophy, including the 1 female carrier of DMD. 24% of the babies that we referred had shoulder dystocia. We've also determined that the following factors affect CKMM levels in newborns: age of collection, birth weight, gestational age, gender, seasonality, and Asian race. The data from the pilot study has been used to nominate DMD to the recommended uniform screening panel. And in October of 2023, in New York State, a bill was passed to perform newborn screening for DMD starting in 2024. So we're preparing for that right now. Next slide, please. I'd like to thank everyone who was involved in this project. Dr. Michelle Kajana is the PI. Sanju, Brianne, and Melissa, research scientists in my lab who performed the screening and the follow-up. I'd like to thank the DMD Steering Committee, Nikki Armstrong, Drs. Buber and Chung, Annie Kennedy, Drs. Perrier and Brower, all the funders of this study, all the recruiters and newborn screening staff at the hospitals and the newborn screening program, and more importantly, all the families who participated in this pilot study. Thank you very much for your attention.
Thank you, Norma, for that presentation. And due to time constraints, I'm going to go ahead and move on to our last speaker, Dr. Holly Piet. Holly, are you still on the call?
I am here.
Great.
Thank you, Jennifer. All right. Well, I think that I can move somewhat quickly through some of these slides because one of the benefits of doing multiple pilots is we do see some concordance in our findings, which is really reassuring for the field. But I will hope to move through this quickly enough that we have a few minutes at the end. It's always hard going last. Next slide. So Early Check is a voluntary newborn screening program under which we run multiple different screening pilots, and we've been conducting screening pilots across the state of North Carolina since 2018. It is a study that is led by RTI, which is an independent research group, but it's conducted in collaboration with our medical centers in North Carolina, as well as our State Laboratory of Public Health. And so we do use the residual dry blood spots, and the State Laboratory of Public Health is a critical partner in our research. We initially began our screening in 2018 with spinal muscular atrophy and Fragile X, and then brought on Duchenne, and I'll focus on that. We have completed our CKMM screening for Duchenne muscular dystrophy, and we are now conducting screening using sequencing, using genome sequencing for panels of conditions. Next slide, please. So again, our study is a bit different than many other studies in that we recruit across an entire state and a diverse state in North Carolina. And our overall goals are to offer infant screening under a voluntary research protocol. This is research. We do consent parents to enroll their newborns in this study across the state of North Carolina. Our objective is to obtain data to inform policy and facilitate transition to state standard newborn screening. And again, Norma already mentioned this, but it's a really nice thing about this study is that our data, and I think all the pilots data really were able to flow pretty directly into an effort to put CKMM screening onto standard newborn screening. We assess outcomes of infants as well as parents and families. I'm going to tell you a tiny bit about that. And then also our study is envisioning a future in which states offer a voluntary panel of non-RUSP conditions. So we, at Early Check, we believe longer term, there will be a set of conditions that flow into state newborn screening, but also a set that really most appropriately remain a voluntary panel of conditions that would not be integrated into state newborn screening. So we look at both kinds of conditions in our program. Next slide, please. People can participate in Early Check, or newborns can participate in Early Check if they're under 1 month old, if they have standard newborn screening in North Carolina, and if there is sufficient residual specimen. We do not have an option to collect another specimen, so there must be sufficient residual dry blood spot remaining for us to do the testing. Mothers or legal guardians enroll their children through our electronic consent portal, and also return results through that portal. And again, we use the state collected dry blood spot, and no additional sample is needed for parents to have their children participate. Next slide, please. To date, we've enrolled over 28,000 newborns across all of our pilots, and you see that our distribution is pretty good across our state. We do have, of course, a focus distribution in areas that are more major metropolitan areas and around our academic health systems. Next slide, please. So as I mentioned before, we've actually retired a set of conditions, including Duchenne muscular dystrophy. We screened for DMD using CKMM from November 2020 to July 2023. And we are currently actually screening for DMD on our gene panel 2 for our sequencing study that is running right now. Next slide, please. All right, I'll tell you a little bit more about the design. We enrolled between 6,000 and 7,000 newborns per year in our study. We do use statewide recruitment, as I mentioned before. Like the other pilot studies, we are using the approved CKMM kit. And our algorithm was a single punch CKMM. We retest in duplicate. And if we have a positive after retest in duplicate, we develop with our advisory committee a neuromuscular gene panel. That's a sequencing-based panel that is performed by what is now known as Revvity Omics. And our initial cutoffs for CKMM, we intentionally, after a verification process, we intentionally set them quite low because our study was interested in exploring what other conditions we would identify with CKMM. So our initial screen was 1275, and after about a year, we actually made that a little more restrictive and changed it to 1626. Next. So of the 16,566 babies screened, we did identify 2 cases of babies with DMD, both males. We also did, and again, please recall that I said we initially set our CKMM level to explore what other conditions we would find, and we did find some. So we had 95 positives. Of those, the majority were male. We did have 80 parents of those 95 who consented to the next-gen sequencing. And you see under the genomic results row there and what we found, we did actually find some carriers for recessive phenotypes, and we found children who we actually expect will have a mild phenotype for other neuromuscular type conditions. Did those cause an increased CK? We don't know, but likely not. Those were likely actually findings that were incidental based on running this large panel. We did offer a second CK test that was not a CKMM, that was a total CK that we had run through a commercial laboratory. Some parents declined. This was also during COVID time and soon thereafter. So asking parents to bring their newborn to a laboratory raised even additional concerns. We can talk more about that if people are interested in that, but we did have most of them come back as we would expect to the normal range. Next slide. I'm going to move a bit more quickly. You can actually go to the next one. So as many other groups were interested, we are also very interested in what other factors are influencing CK levels so that we can provide guidance to the field as we move toward state implementation of CKMM screening. And so upon multivariable analysis, the factors that are independently associated with CKMM levels were greater gestational age that was related to higher CKMM levels, greater age at collection, which is associated with lower CKMM levels. Males had higher CKMM levels. We did find, similar to other studies, that self-reported or card-reported race ethnicity was associated with CKMM levels. But we also overall found that this model with these variables only explained less than 20% of the variance in these predictors by these predictors. And similar to other studies, we did have a very high level of report of perinatal factors, including specifically shoulder dystocia. So we, I think collectively have a lot of evidence that these kind of birth trauma related issues are really likely to contribute significantly to increased CKMM levels. Next, please. So our conclusions for our pilot is that CKMM-based newborn screening is feasible, that biological variables affect CKMM levels, but that actually cutoffs could be based on those factors to improve sensitivity and specificity. that perinatal events have significant impact. And so the work collectively done across our studies, I think, is giving some good guidance to the field about how we might manage these moving forward. And we really need to be focused on options after the initial CKMM test. And that's what I'm going to spend my last minute talking about. So next slide. A follow-on study that we did was we did some assessment with newborn screening professionals about their preference for screening models. And we provided them with 5 different screening models. I only show 3 of them here. And we had interviews, in-depth interviews with 11 professionals from 9 different states to explore their preferences for models. And these are for models for after an initial positive CKMM screen. And the model that was most preferred by the state laboratory personnel was a model where there is a second CKMM with a new sample. And if that is still positive, that there would then be DMD sequencing or duplication deletion testing of DMD to then better characterize the rationale or the reason behind a second high CKMM. The reason why that model was most preferred was because it would reduce the false positive rate in a way that the states found most acceptable, and specifically using DMD sequencing or deletion testing rather than a neuromuscular panel would prevent the states from having to report back results on conditions that were actually not approved for newborn screening. So that model is most preferred, and we have a paper that we're about to submit with these data. I do have one last slide, and I actually will take 1 more minute just to quickly talk about parent evaluation interviews. Another major thing that we're going to have to deal with CKMM is we know we're going to have false positives even after adjusting the rates. And so it is important to understand what happens to families when we provide back a false positive or a increased CKMM result that ends up being a false positive. So we've done interviews, and this is very high-level data from interviews with 20 families who went through early check and had a false positive CKMM result. The findings are not surprising. Parents were upset or worried after the initial positive result. Many of them, that worry was quite modest, but some of them were very concerned. One parent talked about this being the worst thing that had ever happened to them. So we do need to be quite careful about the psychosocial impact. Many were reassured by the genetic counseling, and particularly the genetic counseling discussion of the fact that we know that there's a false positive rate and some of the things that contribute to that. So parents were able to make meaning of that result. There was anxiety in the confirmatory testing time period. And parents did describe that the negative psychosocial reactions were compounded by the fact that this was happening during the postpartum period, where there was already, for many parents, increased anxiety or feelings of being overwhelmed. But overall, parents did not regret enrolling their children in early check, even having gotten a false positive CKMM finding. And most of them said they would definitely enroll a subsequent child if they have another child and early check was still screening for CKMM. So I will end with the next slide is, I think, a picture of my team. This is a large number of people who make this work. So thank you to the team. And I need to make sure to show the funders for my disclosures on the last slide, please. There we go. All right, back over to you, Jennifer.
Thank you. I want to just thank all the speakers. I know we are at 3, but I really want to thank all 3 speakers for the excellent presentation that they gave. I also just want to inform you guys that unfortunately this will be the last NBSTRN National Pilot webinar. We will make this recording available on the NBSTRN website until the contract is over on March 25th. If we have time from our speakers, I would like to stop sharing my screen and open it up for a few questions. I know there was some questions in the chat. I think that Ryan had questions for Dr. Parad about intronic regions, but is there any other questions that we have for the 3 speakers? Ernesto, do you have a question? Holly, I had a question for you about your presentation about the parent interviews. Do you think that you do any assessments for the parents about the understanding of the testing method? Did they understand going into it that there was likely to be false positives?
Yeah, it was part of the consent, but it's not, as you would imagine, it's not something that we highlight in the consent. We do talk about it, the fact these tests are imperfect. And of course, we were screening for, at some points, multiple conditions, some of which actually had very high sensitivity and specificity screening. Yes, and we did have, as one would imagine, we did have a variety of even recall of the study at all. I mean, everyone recalled that they had signed up their baby, but some parents had very little recall of what the study was for. You know, we allowed for the CKMM screening people to sign up prenatally. So some of them had signed up months before they got their result back. And that was a big part of the genetic counseling process, was making sure that families had an understanding of the screening that had been done and sort of revisiting the major elements of the consent and talking about why and how false positive results could happen.
And Dr. Wilcox, I see you have your hand raised. You want to unmute yourself?
Yeah, I just wanted to say thank you to all the staff over the years for working so diligently in the NBS-TRN, and I'm sorry that the NIH didn't see fit to renew your contract. I think it's very sad, and you know, this really isn't the time to be doing stuff like that.
Well, thank you for your comment. We really appreciate that. And I think NICHD is well aware of that. Research and newborn screening is still needed, and there is going to be other opportunities to still conduct research even after this contract is over. So, but thank you again. We really do appreciate your comment. And James had a comment about the CK testing levels, and did anybody see any effects, I guess, about the force that was applied? I don't know how we would measure that. The force applied to the baby's foot to the blood spot. I don't know if any of the speakers have a comment about that.
I would just comment that I don't think it's a massive force, because otherwise we wouldn't have so many babies who had low levels of CKMM. I mean, most babies have low CKMM.
Great point.
I agree. And I think all three of us found that when parents were describing issues that had arisen perinatally with their children, they were really pretty significant birth trauma related issues. They were not as subtle as something like a blood draw or a needle stick, but it is one of the challenges with CKMM for sure.
Well, with that said, I want to thank again the speakers. Oh, does someone else have a question?
See you then Tuesday. Yeah.
Well, again, I wanted to thank the three speakers for their presentation. I want to thank all the participants for attending this last meeting. Again, it will be posted on our YouTube channel. We still encourage you to continue to participate in newborn screening research, and thank you again. Everyone, please have a good rest of your day.
Bye.
Bye-bye.